insights from our expert panelists on the evolving treatment landscape of multiple myeloma, including the role of XPO1 inhibition and potential combinations of different mechanisms for future clinical development. Today's webinar will be moderated by Karyopharm's Executive Vice President and Chief Medical Officer, Dr. Jatin Shah. Dr. Jatin Shah will be joined by Dr. Joseph Mikhael from the International Myeloma Foundation and the Translational Genomics Research Institute at the City of Hope Cancer Center. Dr. Sundar Jagannath from the Tisch Cancer Institute at Mount Sinai Hospital, and Dr. Paul Richardson from Harvard Medical School and the Dana-Farber Cancer Institute. Our esteemed panelists have been paid by Karyopharm for their time preparing for and presenting at today's webinar, and the views they express are their own and not those of Karyopharm or the institutions for whom they work. During our program today, Dr. Mikhael will discuss the evolution of the treatment landscape in multiple myeloma. Dr. Jagannath will then review the results of the STORM study, where the XPO1 inhibitor, selinexor, was evaluated in patients with advanced, heavily pretreated multiple myeloma. Finally, Dr. Richardson will describe evolving areas of interest in mechanistic combinations and rationale for further clinical development. With that, let's get the program underway. I'd like to turn things over to Karyopharm's Chief Medical Officer, Dr. Jatin Shah.
Excellent. Thank you so much, Tanya. As Tanya mentioned, my name is Jatin Shah. I'm the Chief Medical Officer here at Karyopharm. We're very excited to be hosting this presentation today to discuss the dynamic treatment landscape in multiple myeloma, including discussions on the mechanism of disease and retreatment strategies. We'll also take a close look at XPO1 inhibition and its role in multiple myeloma, including a review of the clinical data from the first XPO1 inhibitor evaluated in multiple myeloma. And we'll end with a review of some promising combinations of different mechanisms that warrant further clinical evaluation. I'd now like to welcome Dr. Joseph Mikhael to describe the evolution of a very dynamic treatment landscape in multiple myeloma. Dr. Mikhael is a professor at the Translational Genomics Research Institute at the City of Hope Cancer Center, the Chief Medical Officer at the International Myeloma Foundation, and Director of Myeloma Research and a consultant hematologist at the Honor Health Research Institute. Dr. Mikhael?
Thanks, Jatin. Thanks for being so thorough. As I typically say, my name's Joe. I'm here to give the talk. It's about all people need to know, but I'm very privileged to join this fantastic crowd. And I find it interesting that I've been the one to give the history lesson here in myeloma. I guess I'm showing more and more gray hair all the time, Jatin, so they're getting me to do the walks down memory lane now. But my young colleagues, Sundar Jagannath and Paul Richardson, I know will hopefully share with me in this little history lesson as we go through. So as was discussed, I'm really here to tee things up, to have us thinking a little bit about really the remarkable history we've had in myeloma. I mean, those of us who are myeloma geeks, we talk about this all the time, but we've really not seen another cancer have the kind of transformation that myeloma has had over the last decade. And so my objective here is really to have a quick walk through the history, but specifically thinking a bit more about single agents and the role that they have played with obviously single agent activity in that history. And in doing so, help us understand how important mechanisms are in multiple myeloma, how we are not overcoming this disease with one simple mechanism, but many in combination, but each of those ones must have a significance in of itself. So next slide, please. We will remember that, and I was really actually hoping in time for this talk that I could have updated the slide working with Shaji Kumar and others. We're almost ready now to add the next line of improving survival in myeloma. I always call this the happy and the sad slide. The happy slide part of it is that every time we measure survival in myeloma, it continues to increase. And you see this blue line climbing, and it'll almost land halfway between it and the black line above it. The sad part of the slide is that there's still a gap between the myeloma cohort and the non-myeloma cohort. So we've doubled, and in some circumstances tripled, average survival of myeloma over this period of time, and we continue to see that improvement carrying on. Next slide, please. So I'm not going to go too far back in history, and I'm just going to briefly mention these that, going back to the 40s, we had urethane, melphalan, which frankly still has one of the most impressive single agent activities of any drug in myeloma, made its appearance, and soon thereafter corticosteroids. The 70s, frankly, didn't bring us a lot in myeloma. I mean, it may have brought the world bell bottoms and the Bee Gees and whatever else pervaded the country at the time, but it really didn't bring a whole lot in myeloma therapy until the 80s, when the notion of autologous stem cell transplant, and Sundar and Paul both have tremendous history in this work, really started to demonstrate its benefit in myeloma. And then just before the turn of the century, we really started to see the benefit of more biological novel approaches, with thalidomide demonstrating at least a 30% single agent activity. Obviously, these numbers can vary based on what study you look at. I've tried to give us some generalities. Next slide, please. And then really, this mushrooming over the last 20 years now has seen things change. Hall's tremendous work in multiple studies really introduced to us in the early 2000s bortezomib, with really 38% single agent activity in patients that had relapsed, most of whom had been through transplant or had some kind of alkylating therapy. And soon thereafter, we saw the other immunomodulatory drug come after thalidomide in the form of lenalidomide. And then not too long later, and there are many people on this call who were involved with its development, of course, including Mikhael himself, in carfilzomib, where now every time we're looking, and this is an important caveat that I want you to notice, when we start looking at the single agent activities of these drugs, we're noting them in patients who were refractory to everything that we've seen up until now. So in a sense, they're not being compared head to head. They're being now compared further along the line. And as we know, myeloma evolves with each line of therapy. The marrow is more beaten down with each line of therapy. Patients are older and less able to tolerate therapies as we move each line of therapy. So it's becoming an increasingly difficult environment. I know that there are a lot of football fans here. It's almost like thinking it's one thing to win a game during the regular season, but then you start getting into the playoffs and deeper into the playoffs. You've got more challenges there. You've got more difficult opponents, as it were. And so we saw with carfilzomib and pomalidomide that these two agents, if you will, cut their teeth in single agent activity in patients previously treated with immunomodulatory drugs and proteasome inhibitors of early stage. In 2015, it was a bit of an odd year because we saw two drugs that actually didn't have single agent activity, but clearly did in combination, panobinostat and elotuzumab approved, and then daratumumab, which now was demonstrating itself in double refractory disease to proteasome inhibitors and immunomodulatory drugs. Ixazomib was approved in combination, but the very first studies that Paul and Shaji Kumar published also demonstrated single agent activity. Next slide, please. So as we look at, next slide, please. So as we look at this before we go beyond 2015, let me just give you my simple Dr. Joe's take on what we learned, if you will, through that process. What I would figure as the recipe, as it were, for success. That single agent activity had to be present. That not that agents that don't have single agent activity don't have a role, but their role is significantly limited. That one has to demonstrate, as I've shown, efficacy in heavily pretreated disease. That it has to be compatible, if not even almost, if you will, promiscuous, to be able to partner with different drugs. So it's one thing to have a response rate, and that's what these percentages are referring to, overall response rate, so partial remission and greater, which would include very good partial remission and complete remission. But now being able to partner with other drugs to enhance that response rate, but also not to increase toxicity. So to have tolerable and manageable side effects, that when two drugs are combined together, you're not amplifying the neuropathy or amplifying the cytopenias per se. And then these drugs need robust phase 3 data in earlier use. You cut your teeth, you prove yourself by yourself in heavily refractory disease, but then later on, you need to show that you can combine with others in a large phase 3 trial, comparing to the standard of care, that you can add a significant benefit. The other feature that becomes important, and there are drugs, unfortunately, that haven't met this metric, being able to continue the drug. We've come to appreciate that myeloma is really in many ways a chronic disease, and we don't always have to treat every patient forever, but continuous therapy becomes important. And if there's a certain toxicity that causes you to stop a drug earlier on, it can impair its ultimate benefit. And then, of course, the hope, the dream, is that a drug can not only prove itself in relapse disease and start to work its way back through earlier relapse, but indeed make its way to the big leagues, as it were, right up into frontline therapy. So that's kind of my take on it, as we've seen different drugs do this. And then next slide, please. To demonstrate this a little bit more, we published a paper a few years ago looking at all the different drugs that had been reported at the time. So this is 2014, and really saw that cutoff. In fact, up until then, no FDA approval had been granted to a drug that didn't have single agent activity of greater than 20%. Not that that's a magic number, but it is a significant number nonetheless. Next slide, please. And as I mentioned, the disease becomes more aggressive. We all have seen a version of this slide before, where we know myeloma can harbor multiple clones and with each relapse become more resistant. And this becomes important because it's influencing the way we think about this disease, that we don't save the best till last. That sounds great for a romantic song or movie, but not really ultimately in myeloma, as we are in the field moving our best therapies earlier on to combat the disease earlier. Next slide, please. So lastly, in our history lesson, as I have a few minutes left here, we've come to obviously understanding where we are, and who's hosting us today is in selinexor. And so again, now we have another agent that's cut its teeth in not just double class refractory, not even just triple class refractory, but truly penta-refractory disease. So median 8 lines of therapy still has a 25% response rate. And that's where it's difficult to compare these numbers, but I give them to you to help you understand the significance of these drugs. This several months ago, isatuximab was approved. I had the privilege of leading the first in human study with that drug, where we showed a 24% single agent response rate, obviously amplified with pomalidomide, and it's approved only in combination. And then just literally a few months ago, belantamab, similarly to selinexor in triple class refractory disease, but not mandating penta-refractory disease, with a 31% response rate, median 7 lines. And who knows what's to come over this coming year. Obviously, I'm not going to be a prophet and predict the future, but we expect to see CAR T-cell therapy, melflufen, or the artist formerly known as melflufen, iberdomide, bispecific therapies, and others to come. Next slide, please. So it speaks to us of mechanism. And many of you have seen this slide and even shared this kind of slide before. And I'm not going to go through it in detail, but just to remind you that this disease is not just about the tumor. It's not just about its own self. It's how it interacts with the environment. The pathways within the cell and the pathways without the cell become really important as we look to the future. Engaging T cells and natural killer cells and others becomes really important, because the mechanism of myeloma is by no means one simple CML-like approach. Next slide, please. So as I come to the end here, we've seen this tremendous evolution in myeloma, and I've listed here in red what has been a standard for a number of years. In green, what over the last 12 months or so we have now added to our armamentarium of now introducing more daratumumab frontline, selinexor in relapse disease, isatuximab, and recently belantamab. In purple, what we'll likely see in the coming year as we continue to study this disease more and more. Next slide, please. So at this point, I'm happy to turn it back to you, Jatin, and trust that this quick history lesson with relevance and single agent has been of value, and I'll turn it back to you, boss. I think you may be muted, Jatin.
No, thanks so much, Joe. So really, thanks so much, Dr. Mikhael. Really appreciate that. Really walking through the history of myeloma, providing that context for these improvements in survival, and these really due to new classes of drugs, both new drugs and new classes of drugs. So that's really helpful to really understand where we came from and where we're headed. And I think the recipes of success that you provided for myeloma agents is a key thought process to really kind of help understand that. So that's great. Lots of things for us to consider as we move forward, but really helps contextualize all the data in this dynamic landscape. So I think we'll have some questions at the end for you. But what I'd like to do now is welcome Dr. Sundar Jagannath. Dr. Jagannath is the director of the Multiple Myeloma Program at the Tisch Cancer Institute within the Mount Sinai Medical Center, a professor of medicine at the Icahn School of Medicine at Mount Sinai. Dr. Jagannath was the principal investigator of the STORM study, which was a phase 2b single-arm open-label study of selinexor and dexamethasone in patients with advanced, heavily pretreated multiple myeloma. The FDA granted accelerated approval on July 3rd, 2019 to selinexor based on the STORM study. I'm really honored and privileged to have you join us today to review the clinical data. Dr. Jagannath?
Thank you very much, Jatin. I hope you all can hear me.
We can.
Yeah, good. So we heard Joe said that selinexor cut its teeth on this particular STORM trial. It is deja vu, going in front of FDA, presenting the STORM data and getting the accelerated approval. So let's see why I'm all excited about selinexor. See, once the eukaryotic cell organized the nucleus and separated with nuclear membrane, then the transportation between the nucleus and the cytoplasm, then they needed the chaperoning. So the proteins cannot go in and out very easily. They usually needed an exportin or importin. Importin to bring them in, exportin to export out. Among this, exportin 1 is a major nuclear export protein. And this is important because all the tumor suppressor proteins, or majority of them, they are exported out of the nucleus into the cytoplasm. Once you export them, then of course the tumor suppressor protein is not in the nucleus, the cell can continue to multiply. So exportin is an important way to export all the tumor suppressor protein. And that's being said, the cancer cells have a lot of exportin 1 because they want to continue to multiply. So they throw out all the tumor suppressor protein out. The other one is the eukaryotic initiation factor 4E. This is translation initiation factor 4E. This binds to messenger RNA of oncoproteins like c-Myc, BCL-XL, etc. And they are also need to be exported, and there the protein Myc and all has to be produced because the messenger RNA has to go in. So glucocorticoid receptor, that's an important for the glucocorticoids, dexamethasone to bind to glucocorticoid receptor and then goes into the nucleus and then binds to the glucocorticoid receptor elements. So if you block this whole activity with small molecule orally active selective inhibitor, that's what selinexor is. Then what happens is all of these activities stop. So the tumor suppressor protein accumulate in the nucleus, the oncoproteins are not translated anymore, and the steroid could be retained with the glucocorticoid receptor. So this is why you will find that this is quite effective in the treatment of myeloma. But I believe this will be quite effective in many other cancers too, because it's not just for myeloma. The exportin 1 is overexpressed in many cancers, and this mechanism is very, very unique, and this is an important drug, and it'll turn out to be important in many other diseases. As I said, it is overexpressed in myeloma, and there has been publication correlating the poor prognosis and drug resistance with overexpression of the exportin 1. So selinexor is the first in class orally available selective inhibitor, and now you'll see how this ends up being very effective in myeloma. Next slide. So this is a pivotal STORM trial, part 2, and 122 patients were enrolled on this part 2 expansion study in penta-refractory myeloma. Before, they were triple refractory and some penta-refractory, but the study was designed only to have penta-refractory myeloma enrolled on this study. So the key inclusion criteria, as you can see, was quite liberal because these are advanced myeloma. Quite often they come in with renal impairment. So you have to keep the renal clearance quite liberal, 20 milliliter or greater, which is actually CKD stage 4. So these patients with greater than 20 milliliter per minute were allowed to participate in the trial. And these patients have had so much treatment, so we allowed ANC as low as 1,000, you know, and that's already grade 2, neutropenia. And then you have platelet at 75,000, so that's grade 1 thrombocytopenia using CTC criteria, and hemoglobin 8.5. So you could see we were allowed patient almost in grade 2 CTC criteria into the study, so it doesn't take much to push them into grade 3. And that's important in this advanced patient. The patients were all exposed to Velcade and carfilzomib, lenalidomide and pomalidomide and dexamethasone, alkylators, glucocorticoids, but they were also exposed to daratumumab, and that's important. And the primary endpoint is overall response rate. So it's important for FDA for an accelerated approval. It is the response rate which is the key. So the primary endpoint for the study was overall response rate. But of course, we looked at the duration of response, progression-free survival, overall survival, and most importantly, the safety. The medication was given in high doses because in pentarefractory, we were using a single agent, selinexor, with the dexamethasone. So it is 80 milligram twice weekly with the dexamethasone, 20 milligram twice weekly, which will come to 40 milligram once a week. And so it is, you could see this, I would call as high dose selinexor dexamethasone treatment. And this was given to patient until progression of disease or intolerability. Next slide. So the 122 patients were enrolled, but the FDA looked at very, very closely, and they found that 83 patients really met all the pentarefractory because patients are referred. It is very difficult to document whether they were truly refractory to Revlimid and to pomalidomide, etc. So this is the FDA went through this, combed through this database, and they thought 83 patients met it. 68% of the patients met the pentarefractory population. And in this group, you can see age 40 to 85, with a median age of 65. And, the time from diagnosis could vary, 7 years, but it could be from 1 to 23 years. Creatinine clearance, I already alluded to, patients less than 30 milliliter per minute were allowed, 5%. High risk cytogenetics in almost more than 50% of the patient. But this group, by definition, all of them are functionally high risk because the next option is hospice. So these are functionally high risk patients to keep in mind, in addition to the traditional genetic markers as high risk. And many of these patients, by the time they come, they have ECOG performance status, not that great. So you could see ECOG 2, 8% of the patient were there. And many of them had symptoms, so they're all ECOG 1. More than half of the patient were ECOG 1 or more. And they have quite a bit of comorbidities because of prior treatment exposure and the toxicity from prior treatment exposure, as well as the age of the population. You have cardiac, coronary artery disease, hypertension, renal impairment, all of them comes into play. So quite a bit of comorbidities are there. And if you look at the prior treatments, by definition, FDA combed through, you could see refractory to PI, IMiD, daratumumab, and steroid, 100%. Refractory to carfilzomib, pomalidomide, daratumumab. These are second generation proteasome inhibitor and immunomodulatory molecule, and daratumumab, 100%. Refractory to 2 PI, 2 IMiD, and daratumumab, which is the definition for pentarefractory, 100%. So you can see that these were really refractory patient population. And this is where Joe said that the hurdle to climb, the high jump bar is really high in patients who are pentarefractory. Next slide, please. So what did we get? Joe said as you have to cross 20%. Well, we did overall response rate of 25%. But clinical benefit response, that is the minor response and better, is another 12%. So you have 37.3% of the patient. And I will tell you why clinical benefit response or even minor response was meaningful to this penta-refractory patient later on when we talk about overall survival. Now, if you look at it, the median 8 lines of prior treatment, 2 patients had progressed even after CAR T cell therapy because they were all coming into clinical trial. Patients wanted to be on CAR T. So the patients had failed CAR T and then came to this study. The median time to response is very fast, 1 month. And this is critical to understand, because once you know the patient is responding in a penta-refractory, the motivation of the patient, the motivation of the physician to support the patient, do dose modification, ask them to stay on the drug becomes very clear. So the first month is critical if the patients are going to really benefit from this treatment. You have to be, monitoring the patient closely and also be a real advocate for this in keeping the patient on the study. Median duration of response, you could see 3.8 months. Next slide. And if you look at it, any reduction in the monoclonal protein, so there are patients who had, so-called stable disease, but actually had reduction in the paraprotein less than 25%. So if you include anybody, did they show any response? 66% of the patient had reduction in the paraprotein, quantifiable reduction in the paraprotein. Next slide. Now, this is the overall survival, the red. Let's focus on the red now. That's all 83 patients, and the median overall survival is 7.6 months. Now, if you take patients who had overall response, which is blue, and the black one is, overall response is black, PR or better, and then you have the blue, which is minor response. So here you could see, as long as the patient had minor response or better, or a partial response or better, they did equally well in terms of survival. And the median is not reached. And that's very important, that in such an advanced, that we had a great impact on the life expectancy. And then you look at the green, to say really these are advanced patients, if they didn't respond to the drug, the median life expectancy was very short, 2.3 months, showing that this population truly was. Otherwise, you would have had the patient who didn't respond still go on and surviving, but that's not the case here. Next slide. The adverse reactions are shown on these slides. Hematologic, most common is thrombocytopenia. And then non-hematologic, you see fatigue, nausea, comes up, the weight decrease, nausea, vomiting, and diarrhea, hyponatremia, they are all shown there. And grade 3 or greater is mainly hematologic. You could see thrombocytopenia and anemia coming there. Otherwise, you have fatigue and some nausea, they start going down at grade 3. They are all in a single digit in terms of nausea, vomiting, diarrhea, they are all in single digit. So you have fatigue and hyponatremia, they are in the 22% neighborhood. We'll talk about a little bit more in the next slide. So the question is, how do we manage the adverse event for these patients? So cytopenias, we can do dose reduction, give them drug holiday instead of giving these drugs. You got to remember, this is high dose selinexor, 80 milligram twice weekly, and you can always give 1 week off. You can reduce the dose. You can give it once a week, 100 milligram, if the patient is showing response. So that is a dose modification becomes important, how to support the patient through. In the first month, because these are penta-refractory patients, and you are allowing patients with platelet count of 75 are coming in, or patient already in grade 2 neutropenia, 1,000 or above coming in, you may want to use growth factor support for these patients, or even platelet support for these patients. That's important, so that at the end of 1 month, because the response is very rapid, you will know whether the patient is benefiting or not. And as they respond, the amount of cancer goes down in the bone marrow, so the tolerance goes down. So the tolerance goes down for 2 reasons. Number 1, there is response, so the myeloma goes down, so the bone marrow reserve goes up. And number 2, you are able to dose modify, so the tolerance goes up. So we can handle the cytopenias. The next one is the gastrointestinal. This is where we have learned, as this drug we have used, now we know we can use ondansetron, which is the 5-HT3 antagonist. I usually give them 3 times a day for the first couple of days automatically round the clock rather than waiting for them to complain of nausea. And then using olanzapine or Zyprexa at bedtime is also very helpful for these patients. And then you can use, rolapitant, which is the NK1R antagonist, which is only once every 2 weeks. That helps very well. It's called Varubi. It helps with the nausea phenomenally well. These were not effectively used during that particular study, but now we are using it routinely, and we find the tolerance is better. And of course, you want to make sure the patient is having adequate hydration and nutritional supplementation. Fatigue, you may want to follow the patient closely for the fatigue. This is important, and especially they may be mildly dehydrated, they're nausea, they did not eat or they didn't drink. So keeping them well hydrated, supporting their anemia, all of that will help. Some people have used, methylphenidate or Ritalin to help with these patients, but I'm not usually advocating that. And then, of course, hyponatremia easily handled with the normal saline in your infusion center or giving them salt tablets. Next slide. So now it is Paul Richardson's role. Okay, I'll sign off. Back to you, Jatin.
Excellent. Thanks so much, Dr. Jagannath. Appreciate that for reviewing this data with us today and your leadership on this study. Importantly, appreciate reviewing the mechanism of action, as this is key with this new field and this new class of drugs to really understand this new mechanism of action. And the science is powerful, as you saw with the clinical data you reviewed. So thank you for that. I'd like to now welcome our third speaker, Dr. Paul Richardson. Dr. Richardson hails from the Dana-Farber Cancer Institute, where he's a clinical program leader and director of the clinical research at the Jerome Multiple Myeloma Center. Dr. Richardson is also the R.J. Corman Professor of Medicine at the Harvard Medical School. Today, Dr. Richardson will review the mechanistic rationale for combinations in relapsed refractory myeloma. Dr. Richardson, welcome.
Great. Thank you very much, Jatin, and it's lovely to join everyone. And thanks so much for a wonderful set of introductions from, on the one hand, just now Sundar, and of course, just before that, Joe. As you heard so nicely from Sundar, we've got a platform of a novel mechanism of action, which is absolutely critical in this triple class refractory penta-exposed population of patients. But obviously, as a single agent, having demonstrated that important signal, and particularly looking at the responder analysis and those patients in that category as to how long disease was controlled, was particularly striking. The question then becomes, what do we do in terms of combinations? Because clearly, in my opinion, that's absolutely the way forward. So with that in mind, my next slide, please, if that's possible. Lovely. I want to sort of do a quick background to share with our audience. As we think about multiple myeloma, it's very appropriately named. It is truly an incredibly heterogeneous group of diseases encapsulated in one terminology. And it's highly complex at diagnosis, but it's even more so at relapse because of obviously genomic events and what we call clonal evolution. And on the right side of the slide here, I show whole genome sequencing, courtesy of my colleague, super colleague, Mikhael Munshi, from a patient of ours in one of our clinical trials, who basically had whole genome sequencing done at diagnosis, where there are over 5,000 mutations. And then after induction remission therapy, transplantation, consolidation and maintenance, the patient then relapsed. And at relapse, there are 12,000 mutations. So you can fully appreciate that this extraordinary complexity of disease is something that we really have quite a task to overcome. So the fact that we have a novel mechanism of action with selinexor uniquely in its space, and the idea of putting a combination strategy in place really makes sense to try and get our hands around, or a net around, this disease process. Next slide, please. Now, this just goes into more detail of that exact whole genome sequencing, and I just bring it out visually for you because I think in that last diagram, it's a little bit less clear. But as you can see, 5,000 mutations at diagnosis. And then next slide, please. It moves forward, hopefully. Next slide. Oh, here we are. Yep, 12,000. So the critical point. Now, what's interesting here, and a point that's worth making, is that actually the signal in terms of the mutagenicity of this particular patient's disease is quite complex and points to a very adverse pattern emerging after therapy. So it actually also matters what we do in terms of our treatment, because there's certainly the hypothesis that there is actually now some substantial data behind that certain treatment strategies can actually engender even greater genetic change in the disease. And that's why, again, this whole novel mechanism of action that's driven by selinexor is, I think, particularly attractive. Next slide, please. Now, another basic sort of background point is that there's a critical interaction between plasma cells and the bone marrow microenvironment. This is an older slide from a very nice review a few years ago by Antonio Palumbo and my mentor, Dr. Ken Anderson. But what you can see here, as illustrated well, is this interaction not just between the tumor cell and the bone marrow stromal cell, but critically also with the bone microenvironment, as well as other aspects of the physiology and microenvironment within which the disease lives, very specifically the immune milieu, as we're beginning to better understand it. Next slide, please. And this is actually a construct that sort of drives at that question. How do we use the multimodality targeting of myeloma in the context of this microenvironment to improve outcome? And I show this to you because it's now such a well-established platform for us in terms of how we think about myeloma therapeutics. And you can see as you go around the grid here, starting at A at the bottom, where we're looking at proteasome inhibition as a platform of therapy, and then move into the space of antibodies. And then as we think about this, into the more complex immune microenvironment that we can target. And then finally, a variety of strategies that can target the epigenetics of the disease. And then as you swing around to category E, you can look here at what we're thinking in terms of dendritic cells and checkpoints. But what's so impressive and important, and obviously this particular schematic antecedes the success of selinexor in this space, we now have an entirely novel mechanism of action to add to this particular construct of multiple approaches to the combinatorial strategies in targeting myeloma. Next slide, please. Now, this is, again, an older slide, but I just show it to you to give you where the idea of these rational combinations has been built over many years of hard work in the space of novel drugs for myeloma. And this was from a few years ago from a clinical cancer research review where we schematically hypothesized that you had a rationale for putting together varieties of novel drugs. And next slide, please. And as you can see in that context, we now have third generation immunomodulatory drugs. We have, of course, next generation proteasome inhibitors, including carfilzomib and also ixazomib. And most importantly, we now have monoclonal antibodies. So as we think about combination strategies, I think this illustrates very well how we might then rationally try to put together new mechanisms of action, particularly in heavily pretreated patients. Next slide, please. Now, we have multiple options now available. And the critical thing is that they have different mechanisms of action. I'm sorry that this doesn't project terribly well, but what I've illustrated here, obviously, is selinexor in the key position, but also belantamab mafodotin here, and also in the same context, isatuximab and elotuzumab. But in any event, you can see now that we're in a position with 12 novel drugs that we can think rationally about different mechanisms of action to augment outcome. Next slide, please. Now, in terms of thinking more about XPO1 and the novel mechanism of action of selinexor, I think it's well worth sharing some of this information. High XPO1 levels are clearly correlated with poor prognosis for our patients. And in that regard, strategies aimed at targeting this pathway may be therefore of particular importance. Next slide, please. Now, we've already heard very nicely about mechanism of action, but just a few points of emphasis to bring out. In terms of inhibition of XPO1, it's critical to understand that XPO1 overexpression enables the cancer cell to escape tumor suppressors and actually, in that context, escape pathways for induction of apoptosis. And this clearly, as I mentioned, correlates not only with poor prognosis, but clearly underpins drug resistance. And then in terms of inhibition, the inhibition of XPO1 classically impacts tumor cells by what we think are three core mechanisms. Obviously, increasing the nuclear levels and activation of tumor suppressor proteins, a critical construct in myeloma. But I think what's also very important is that it traps the oncoprotein messenger RNA in the nucleus, leading to reduced oncoprotein levels. So that whole mutagenic thrust that I tried to emphasize and show you earlier is suppressed by this mechanism. And in that same context, there's the retention of the activated glucocorticoid receptor in the nucleus, which is why you heard so nicely from Sundar about the combination of selinexor with steroids was particularly important, actually, because this mechanism may be particularly relevant in that setting. And I think what's particularly attractive as well is as you think about these particular tumor suppressor proteins that are relevant in myeloma, there is the classical pathways of NF-kappa B signaling and c-Myc that may be modulated through this mechanism. So that underscores certain pivotal drugs we use, be they immunomodulatory drugs on the one hand and proteasome inhibitors on the other. So it's actually no surprise then that there's synergistic activity in combination with bortezomib, pomalidomide, and lenalidomide, and we see this not only in vitro, but in vivo. As I've mentioned already, there's this signaling pathway from dexamethasone that's very relevant. Now, I think one other key point to bring out here is also evidence that's emerging about what I consider one of the most vulnerable populations we have, those with 17p deletion. And clearly we have a lot of preclinical information that supports the notion that selinexor and the inhibition of XPO1 may be vital in going after that particular mechanism. Next slide, please. Now, in terms of XPO1 inhibitors in combination with IMiDs leading to reduced tumor growth, I just want to show you some preclinical information from a variety of colleagues. This is, I think, very nice preclinical data in MM1S cell lines where you can see, obviously, the impact of vehicle, none. And in that same context, you can see that there is clear synergy when you combine selinexor with lenalidomide. So there's an effect from seli alone, there's an impressive effect from lenalidomide alone, put the two together, and it's even better. Next slide, please. Now, in that same context, what about monoclonal antibodies? Well, if you think about how monoclonal antibodies work, it's a very rational hypothesis, particularly with CD38 targeting, that there would be synergy potentially with XPO1 inhibition. And why so? Because daratumumab and antibodies like it have multiple mechanisms of action in the way that they actually engender myeloma cell death. And it's not just simply through the immune system, but it's also through direct apoptotic mechanisms as well. So there's a strong rationale why there should actually be synergy with selinexor. And in this particular experiment, you can see here that the use of selinexor in combination with daratumumab resulted in a potent inhibitory effect on CD138 positive myeloma cells derived from myeloma patients in the newly diagnosed setting. And that's what's really also interesting is that in the non-myeloma cells, and this is critical, there was no exacerbation of effect on again, non-malignant cells. So a very important observation here in this particular study. Next slide, please. And then again, more preclinical data, which I think is particularly visually impressive to me anyway, and impressive scientifically about the potency of XPO1 inhibition combined with proteasome inhibitors. And I think in terms of understanding mechanism, one of the really nice things to sort of realize is that proteasome inhibition potentiates the inhibition of XPO1 by selinexor because there is actually increased nuclear localization of Icappa B and inhibition of NF-kappa B, which are these absolutely pivotal pathways in myeloma biology. And this graphic illustrates this extremely nicely, and I think is particularly visually obvious if you look at the synergistic effects of selinexor combined here in combination with bortezomib in these proteasome inhibitor resistant myeloma cell lines. Next slide, please. So if we then look further at this and look not only at bortezomib, and you can see on the left here bortezomib having a profoundly synergistic effect. If you look at the vehicle and look at bortezomib in the blue line, what's interesting actually in this model system is selinexor actually is that much more impressive in terms of tumor volume on its own compared to bortezomib, which is very interesting in my view. But again, when you combine the two, there's clear synergy. And of course, the same observation is made for carfilzomib, even more so in my opinion for carfilzomib, recognizing obviously these are different cell lines, so one has to be careful, but it's still striking to me the synergy that we see with selinexor preclinically with carfilzomib. Next slide, please. And then I think, intriguingly, this is a very nice experiment which shows the potential role of XPO1 inhibition, or the use of a selective nuclear export protein inhibitor, in this case, eltanexor, or ELTA as I'll call it for short, in this particular preclinical system. And what you see here is an interaction with venetoclax, which clearly shows that the combination of ELTA with venetoclax enhances apoptosis and leads to loss of clonogenicity in colony assays. And I want to share with you just a story around a patient in whom my next choice of drug is going to be selinexor. She has very aggressive disease. It's now 17p deleted, and she expresses 1114. And unfortunately, on maximal doses of carfilzomib, dexamethasone, cyclophosphamide, and venetoclax. So that's about as powerful platform as we can put together. By the way, unfortunately, she relapsed after RVD daratumumab, and so was particularly worrisome because daratumumab had failed her. She now has aggressive disease that's on the march, and I'm combining selinexor with my next repertoire of drugs to challenge her now, exactly on the basis of some of this information here, because it may be a very rational approach in the management of her disease. In any event, I think intriguingly, this combination data points that with our major classes of drugs, be it proteasome inhibition, immunomodulation, and antibodies, there is a strong rationale for combining with selinexor. And very importantly, in the setting of venetoclax, that may be equally important too. And why I'm so fascinated by that personally is that venetoclax constitutes, in my opinion, a very important advance in translocation 1114 positive disease. One of the worries is when it fails, what do we then do? And in this setting, it's very interesting to see preclinical information like this, because that may guide us with rational strategies, perhaps even to prevent that in patients who have this particular translocation, and do so with drugs like selinexor. Next slide, please. So these are my conclusions, and they're more a sort of broader thing for discussion. But as you can see, and as I think all of us are familiar, innovations with proteasome inhibitors, immunomodulators, monoclonal antibodies, and I should also mention histone deacetylase inhibitors as well, have produced significant improvements in clinical benefit. And recent approvals, in my view, will augment this. Now, it's very relevant to share with you 12 novel drugs in the last 20 years or so, over 28 new approvals for combinations and indications. And of course, we have great new immune therapies coming, which may be agnostic to mutational thrust. And obviously, baseline immune function is key to the barrier to that success, and therefore, is an important thing to target. But whilst I do think we've got monoclonal antibodies and immune therapies that are so promising, we also have to recognize that they fail. And as we think about how we go after this, I think it's particularly exciting that we have entirely novel mechanisms of action, such as selinexor, such as venetoclax, and other drugs that will be available to us. So in my opinion, the combinations of integrating these novel mechanisms of action and so improving on what you saw so nicely from Sundar in terms of a baseline signal can actually become a reality. And as we further approach this, the refinement of prognostics. So for example, if I use my patient example, how can we better understand how she may or may not do? How can we best combine drugs for her? Can we look at her immune profiling? And then of course, in patients who achieve high quality responses and achieve true complete remissions, how can we use tools like MRD to better inform our treatment choices? And I think I'll close there, Jatin, in the interest of time. And thank you for everyone's attention.
Excellent. Thanks so much, Dr. Richardson, for reviewing the really evolution of the field based on the science driving these rational combinations. Clearly, lots to think about here as the myeloma treatment landscape continues to evolve. Again, I want to thank Dr. Mikhael, Dr. Jagannath, and Dr. Richardson, really a tour de force from our expert panel, reviewing a field which is rapidly evolving, reviewing the clinical data of XPO1 inhibition with Dr. Jagannath, and really Dr. Richardson for laying out a bright future with rational combinations. One question did come up, and so for those folks who put questions in the chat, we've captured all those, and if we have your contact information, we'll follow up on that. Just one question for Dr. Mikhael. With all these new drugs, and I think for the panel, how do you see the field evolving where we get the most out of all of our tools with these new classes of drugs?
Yeah, no, it's a great question, Jatin, and one that we discuss at length, and I'd be interested to see, of course, what my colleagues think, but maybe just share the principle, which is, I think, this notion that we would ever save the best for last has really kind of moved away from our thinking. There's always been this tension in myeloma, are you of the cure camp or the control camp? Are you the Barlogi, Jagannath, let's, get in there, we're going to find them, we're going to get them, give everything up front, or the Raj Kumar Mayo kind of treat it like hypertension, just enough to control it, to try to keep a lid on it. And I think everyone recognizes that both extremes are probably not ideal, but I think the field is tipping more towards combining, as Paul beautifully explained, multiple mechanisms of action when there are several clones or potentially several clones up front because that first remission is often the longest remission. So I think we're going to see a strategy. It may not be all exactly in first line. I sometimes call it the 1-2 punch. You know, the frontline therapy and first relapse are thought of almost as a combination, as it were, a strategy that together will be using multiple mechanisms of action, as evidenced by going from doublets to triplets and almost definitely soon to quadruplets. That's kind of the principle. I'll see if, you know, Paul and Sundar want to chime in with more detail than that.
Sundar?
Well, you put it succinctly. I believe in curing myeloma and not keeping it as a chronic disease or just, I want to give 2 drugs at a time and keep them around and things like that. I want to cure and get the patient back their life and quality of life and get going. So I think you will eventually come to it, whichever way you look at it, and I will stop there.
Well, I think I can sort of take a sort of position somewhere in between those. And I think I do agree with Joe. I think combinations of treatments are essential going forward because they give us, in my opinion, the best chance of clonal control and avoiding this kind of mutational thrust that can actually generate very adverse outcomes in the longer term. I think Sundar touched on a very important point: minimal disease, functional cure, and quality of life. And I think that's why I come somewhere in the middle, because I think it's very important to recognize how critical that is. And whilst I think in our younger patients with excellent performance status and really, you know, are free of comorbidities that preclude intensive therapies, those approaches make sense. Although we're already recognizing the evolution of that therapeutic space, because as we move to CAR T and novel immune strategies, and we move away from some of the older approaches that were great war horses in the past, but maybe less attractive going forward because of long-term consequences. So as we put all of that together, I think that something like selinexor with an entirely novel mechanism of action really is attractive, because bringing that earlier, you know, how do we then optimize the biological effect that that can have? And what I'm very struck by, Jatin, is that, for example, in Sundar's presentation in STORM, the twice-a-week dosing of selinexor was active but challenging. Now, frankly, we routinely use it weekly, and we use it weekly in combination, and it's much better tolerated. And I think that points to the fact that we can move much earlier. And of course, we have the excellent data from Boston, Jatin, which shows that that's a feasible approach that can translate into clinical benefit. So I'm very excited about this combination strategies, and I think they are going to provide us with the vision that Sundar's looking for, which is, you know, functional cure, as I kind of like to think of it.
Oh, excellent. Thanks so much for great discussion, great viewpoints there. One of the questions that came up in the chat was actually management of extramedullary disease. We had a patient who was diagnosed with myeloma in her pancreas and a mass in her pelvis. Any thoughts on just approach to myeloma with extramedullary disease? Dr. Jagannath, we'll start with you.
Yeah, I mean, in the context of this meeting, selinexor works well even in extramedullary disease, to put it out there in terms of statement. Number 2, extramedullary disease, especially in pancreas and liver, generally are, you know, worse prognosis. Quite often these people have elevated LDH, and when they presented aggressively like that, in the olden days, we would have resorted to DSEP chemotherapy. It is a lymphoma-like regimen, or VDT pace, and it often puts them into remission. Nowadays, I have to say that even the extramedullary disease are, you know, amenable to newer agents such as bispecific and CAR T cell therapy too. So I think we are getting many more treatment armamentarium. But today, I just wanted to say that selinexor works in extramedullary disease, and selinexor also crosses the blood-brain barrier. So this is one of the few drugs that crosses the blood-brain barrier. So those are all important things to keep in mind. Any drug that is, you know, is able to penetrate and goes to the CNS and goes into, you know, all these different organs is more effective for extramedullary disease also.
Yeah, and I'd love to build on that, because I mentioned 17p before. we know in extramedullary disease that 17p tends to be enriched. So in my opinion, selinexor constitutes an excellent choice for extramedullary disease as part of a combination approach, for all the reasons that you heard so nicely from Sundar, Jatin, but in addition to that, because the genetic profile of this type of disease is typically enriched for 17p, and of course I think there's such compelling evidence that selinexor is outstanding in that setting. And sorry, Joe.
No, not at all. I mean, you captured it. I was about to focus on that point as I do think is important. I think that's where the combination is particularly important. Is as Sundar said, unfortunately, not all extramedullary disease is the same. Sometimes we speak about it as this sort of phenomenon that is unifying, but it really isn't necessarily. There's a difference between de novo and relapse. When someone, for example, has oligosecretory or even non-secretory disease and only presents an extramedullary disease, and also the location of it makes a difference. And when we see it in the liver, when we see it in the pancreas, it is often tragically very, very terminal. So in those situations, absolutely, we need agents that can penetrate into those areas. Sometimes we also, add radiation or other forms of localized treatment to try and enhance that effect. But it's a tricky situation, and it's challenging to deal with.
Excellent. Thanks so much. Great discussion again. Great insight and feedback on that question. It was very difficult disease very difficult to treat the disease. And with that, I think just want to wrap up and thank again all of our panelists for their joining us today and tremendous insights and a great conversation. We'll continue this dialogue. And with that, I'll turn it back over to our host for today's program, Tanya Lewis.
Great panelists. I'm really excited about the future. And I'd like to thank you, Jatin, and thank all of you for joining us today. We appreciate the time and tremendous insights provided by our esteemed panelists. We hope that all the attendees benefited from today's presentation. We're excited to share that there will be future events like this one. Please visit our website and follow us on social media for more information on upcoming events. This session has been recorded as well, and you will be able to revisit on our website and YouTube page at any time. We hope to see you again for one of our upcoming webinars. Thank you all again for joining us, and enjoy the rest of your day.
Thank you very much, everyone. Thank you.
Thank you.
Thank you very much. Bye-bye.
Bye-bye.